Penguin Random House Audio presents Booster Shots, the Urgent Lessons of Measles and the Uncertain Future of Children's Health. This is the author, Adam Ratner, MD, MPH. For Sherry and Samantha, always. It all depends on whose baby has the measles. Franklin Delano Roosevelt. Introduction. I am a pediatrician. When I was about 15 years old, my brother Gabriel, a toddler, fell into the swimming pool in our backyard. I was in my bedroom, bored, annoyed, working through a review book for an upcoming standardized test in biology. My mother was unloading groceries. She had unbuckled Gabe from his car seat and thought that he was following her into the house. Instead, he wandered around the side, up a short set of stairs, and into the water. My room had a window that faced the back of the house, but I didn't hear him fall in. No one did. I hadn't even realized that they were home. This was a moment when some safeguards failed, a couple of minutes in the course of a lifetime. An unlatched gate, a distracted adult, an older brother who wasn't listening. My sister, only a few years older than Gabe, found him floating on the water, pale skin, bloated diaper. For a lot of families, the story ends there. Attention lapses, a safety plan fails, and a child is lost. I'm grateful to say that we were luckier than that. My mother, trained as both a pediatrician and an anesthesiologist, pulled him from the pool. Drawn by my sister's cries, I arrived, wanting to help but shaking and confused. I had never shook before. Mom gave orders. I called the emergency number, explained the unimaginable, blurted our address. I have no memory of what I said, but I do remember doing chest compressions, one hand on a minuscule chest as she breathed for him. It was my first time seeing, much less helping to do, CPR outside the border of a television screen. This is where a story of bad luck becomes a story of good luck. An ambulance arrived. Gabe went first to a local hospital and then, on a ventilator, to a children's hospital in the city. He spent weeks in their pediatric intensive care unit, a mammoth, crowded room packed with a strange juxtaposition of beeping technology and mismatched lengths of tubing strung together with pink latex tape. A team kept careful track of Gabe, and he held up his end of the bargain, slowly healing, needing less support from machines as he went along. I visited him there, held his hand, and watched his protectors. I've been a pediatrician for decades now. I've spent plenty of time in intensive care units and have certainly seen much worse endings. Still, I tear up replaying these scenes in my mind. This is not a medical school application essay. Gabe's hospitalization was no moment of career epiphany for me, but there was a clear message in that experience, and it's one that I consider just about every day. The upshot is this: there is danger in the world, particularly for children. Real, present, and meaningful danger. Sometimes we're lucky enough to have figured out ways to mitigate some of that risk. Think seatbelts, child-proof medication caps, vaccines, and, yes, pool fencing. And sometimes, when prevention fails, the outcome falls to luck. The prevention side of things failed for Gabe. Nothing stopped him on his journey to the backyard. He survived because his mother knew what to do. A well-stocked ambulance was near enough, and the magical machines and people of the ICU were available to him in the wealthy country of his birth. He was lucky. Our whole family was. I think about that a lot. I went to medical school and did my residency at the hospital where they took care of my brother. Working in that pediatric ICU was inspiring and, if I'm being honest, mind-bendingly exhausting. I was never cut out to be a critical care doctor, but I'm a puzzle solver. And I found a subspecialty that lets me spend my days caring for children with complicated diseases and thinking about how to make kids a bit safer tomorrow than they are today. The field of pediatric infectious diseases, ID, is perfect for the way that I think. It's a little slower than critical care. We spend a lot of time digging through patient charts for clues to a difficult diagnosis, consulting journal articles and textbooks, and often calling a colleague who might have the experience or the different approach that we need to turn a stream of contradictory data into a coherent story. As a result, my pediatric ID friends and I also accept a gentle ribbing from other specialists about the lengthy and sometimes absurdly detailed medical histories that we take. Diagnosis is at the heart of being an infectious diseases specialist, and it was what got me hooked on the field. In front of my medical student eyes, weeks of unexplained fever became a newly confirmed case of tuberculosis that responded quickly to medications. Questions, a physical examination, an x-ray, a lab test or two, and a cure. A different pace and a different kind of magic from what I had seen at Gabe's bedside. During the first week of my infectious diseases fellowship, when I was a fully trained pediatrician but just starting my subspecialty education, I saw a child who had recently returned from visiting relatives in Côte d'Ivoire. He had been fine for the weeks in West Africa and even on the flight home, but just a few days later had become extremely ill. High fevers, vomiting, and eventually convulsions. The doctors in the emergency department stopped his seizures with medications. Thanks to the ICU team, he was stabilized and carefully monitored. My job was to help figure out what caused his dramatic change, and as I entered his room, I silently ticked off possible causes of fever in a returning traveler: typhoid, malaria, pneumonia, and others, reminding myself of the important questions to ask. The boy's mother held his hand, and both parents were patient with me as I had them go over the story of the trip, the return, their son's illness. Where had they stayed? With his mother's family, in a town, not a city. He had spent his days outside, running around with his cousins. No, he hadn't had any undercooked foods, no unpasteurized milk, no contact with farm animals. Yes, there were mosquitoes around, but they didn't recall him complaining of bites. No, he had never been sick like this before. This was his first time in a hospital since he was born. He was up to date on his vaccines. In fact, his mother said, he has never had to take any kind of medication for anything, not even an ear infection. A voice in my head. No prophylaxis for the trip. I asked, but no one had prescribed medicine to prevent malaria during his time in a place where the infection is prevalent, a too common oversight, especially for children. A drop of this child's blood on a glass slide revealed the diagnosis. A little while later, in the hospital's laboratory, the senior parasitologist had to help me as I struggled to focus the microscope. But once he did, even my essentially untrained eye couldn't miss the red blood cells teeming with blue-stained malaria parasites, each one a circle with a darker, thicker projection on one side like a wedding ring. The fevers, the seizures, his parents' fear, all of that was downstream of the drama that we saw playing out under the microscope. Our team prescribed medicines that I had never heard of before that week, drugs with names that sounded like spells to me: quinidine, mefloquine, atovaquone proguanil. These and a multitude of other images and spells are the knowledge that I now get to teach to a whole new generation of students, residents, and fellows. Even before we had a global pandemic with which to contend, the past few decades have been an incredible time to be interested in infectious diseases. My training in urban hospitals in the United States focused on caring for individual patients. I strove to be the best doctor that I could for the patients in front of me. Diagnose, treat, repeat. Even with the steady workload, some of the broader trends we saw in the hospital and the clinics were impossible to miss. There were everyday diagnoses like rotavirus, which could cause diarrhea so voluminous that children would come into the hospital with bone-dry lips and skin that tented, staying in place when gently pinched into a mound rather than snapping back into place. Or like respiratory syncytial virus, a hard-to-spell pathogen of young infants that generally goes by RSV. We learned to recognize the quick, shallow, noisy breaths of a child with RSV, to count the number of breaths in a minute, to listen carefully to their lungs, to distinguish a kid with an impending pneumonia from one who was on the mend. These were the illnesses that got turned into shorthand. There's a new kid with rota in 810, on IV fluids but still looks a little dry. Keep an eye on that baby with RSV tonight. She's working hard to breathe. We would even plan for these seasonal diseases in advance, knowing how crowded and chaotic the hospital floors would become once winter hit. There were other infections that we saw only occasionally but worried about daily. Infants and toddlers arriving in the emergency department with fever would often get a rule out sepsis workup, with the goal of figuring out whether they had bacteria in their blood or, worse, their spinal fluid. Most of those evaluations were negative, false alarms triggered by one or another of the million minor infections of childhood. But the ones that were positive were mostly due to Streptococcus pneumoniae bacteria. Those rare hits made the workups worth doing, as a child sent home with a missed case of meningitis, when those bacteria travel to the fluid that encases the brain and spinal cord, may be dead by morning. Early diagnosis and treatment with the right antibiotics could head off a tragedy. The most striking thing that I've seen.
Sample complete. Ready to continue?